Hello and welcome. My name is Joseph Irasheta. I have a Master's of Pharmaceutics from the University of Washington, Seattle, and I'm currently an employee of Missouri Breaks Industries Research here on the Cheyenne River Sioux Reservation in South Dakota. I'm the lead author on the paper Diabetes and Kidney Disease in American Indians, a Potential Role for Sugar-Sweetened Beverages. I've written this paper in conjunction with Dr. Richard Johnson and his lab at the Anschutz Medical Center, University of Colorado, Denver. Our paper represents a review of the available literature about obesity, diabetes, and kidney disease in American Indians. As with many populations, obesity, diabetes, and kidney disease is on the rise. Currently, 5.2 million people in the United States are American Indian, or 1.7% of the total U.S. population. American Indians are 60% increased risk for end-stage renal disease, 40% are obese, and 18% are diabetic. If they are diabetic, they're at a 7-fold greater risk for end-stage renal disease. In our paper, we've cited several studies with 27 genes that have variation that have been associated with obesity, diabetes, or chronic kidney disease. For various reasons, we've separated these studies into American Indian, Mexican or Mexican American, or PIMA. And we recognize in the paper that the PIMA is the most researched American Indian group in the United States, and we also cite that for a variety of reasons, they might not be representative of American Indians as a whole. We also cite the angiotensin converting enzyme insertion that is at relatively high frequency compared to the rest of the world, higher in American Indians. This angiotensin converting enzyme insertion might be a possible reason for the cardioprotective effects we see in American Indians who are obese and have diabetes. It's been shown in a few studies that American Indians suffer at lesser rates for cardiovascular disease and hypertension, although studies like the Strong Heart study have shown that they've already matched non-native groups. We cite differences in diet and behavior. Although 500 years seems like a long time, biologically it's not a very long time. We cite different populations of American Indians that were or still are long-distance runners, and we theorize or suggest that American Indians of many different locations around the US and Canada had this behavior, and they no longer do this. They also had a diet that was richer in tubers and hard to digest carbohydrates than they currently consume, and this dietary transition might be in part a reason for the rise in obesity, diabetes, and kidney disease. We also cite that in the past they've been heavily reliant on game animals, and game animals compared to domestic herd animals have a more favorable omega-3 to omega-6 ratio, which has been shown to be cardioprotective. We also bring up the fact that some of these drivers might not be genetic but rather socially determined. The comparisons of the PIMA on both sides of the U.S.-Mexican border have very different outcomes for obesity, diabetes, and kidney disease. The PIMA on the northern side of the border have a much greater rate of these and have a higher BMI, while the ones on the Mexican side have far less. Social determinist researchers think this might have to do with social stress, access to appropriate diet, and economic barriers to living a traditional lifestyle. So given all of that put together, we still cite that a lot of studies show these different gene variants that are associated with obesity and diabetes in varied populations that don't share ancestry. So there must be either a social driver or some third component that we aren't currently looking at that is causing this commonality between various ethnic groups. Here at the end of the paper, we cite sugar, or high fructose corn syrup, as a potential driver for obesity and kidney disease and diabetes in many populations. In the Strong Heart study for American Indians, We cite that this might have to do with uric acid transport and three uric acid transporters. One's called URAT1, ABCG2, and SLC2A9. Dr. Johnson's lab has shown that these might interact with a fructokinase enzyme in the kidney that creates kind of a cycle of fat storage when you have a diet high in fructose or a sugar. And we cite that some of these variations in the fructose kinase gene are at high prevalence in American Indians, and that we should be doing more research in this interaction. However, also at the end of the paper, we cite that there has been very little research done in American Indian populations, and there's some policy reasons for that between the federal government and the tribes that have yet to be worked out. It also, the context of having a nation within a nation creates certain social drivers and access to resources that make comparisons of health outcomes, social determinant theory, and even genome associations difficult when you're comparing to urban minority populations or other populations in the United States suffering under the same problems of obesity and diabetes. So we are calling for a policy change and more research action with emphasis on public health funding and public health intervention strategies to reduce the epidemic of obesity, diabetes, and chronic kidney disease in American Indians. Thank you for listening. My name is Joseph Hirschetta.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.